This is my first foray back into a Zoom meeting after my computer crashed and I reinstalled everything. So if I suddenly drop off or something, you'll know why. But I'm hoping that doesn't happen. Okay, we already have 42 people signed in. So I think why don't we start, and we'll have people joining as we get going. But we have a whole group of presenters today, so I don't want to skimp on your time at all. Welcome. So we'll start with a land acknowledgement. Ottawa is built on the unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. We also honor all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. So today we're going to have a group of our PGY3 residents at CHEO presenting about flu. Looking for the title here. Good title. The flu facts and it says the friction, but I think that's the fiction, or is it the friction? It's the friction. Yeah, excellent. Okay, great. Looking forward to hearing more. Updated influenza vaccine guidelines and effective strategies for pediatric uptake. And our presenters will be Alyssa, Gaerke, Kristine, Jeganathan, Hannah Cummings, Ashley Buffone, and I don't know if Anne Famhui is going to present or if she's part of the team, not just, but a key part of the team. But Anne is the supervisor for the presentation. So as I mentioned, Kristine, Alyssa, Hannah, and Ashley are all pediatric residents in their third year. And Anne is is our immunologist at CHEO, but also an ID physician, so very well placed to help supervise this presentation. So with that, I'm going to hand over to the first presenter, and then we'll go from there.
Good morning, everyone, and thank you for joining our Grand Rounds presentation. Like Dr. Chakraborty said, my name is Kristine Jeganathan, and I'm presenting alongside Alyssa, Gaerke, Ashley Buffone, and Hannah Cummings, and we're third-year pediatrics residents at CHEO. And this presentation was prepared under the supervision of Dr. Anne Famhui. So today we will be discussing the flu, the facts, and the friction, updated influenza vaccine guidelines, and effective strategies for pediatric uptake. Each year, the influenza season presents ongoing challenges for pediatric care. We see increased respiratory admissions, higher emergency department volumes, and recurring questions from families about the safety and necessity of the flu vaccine. Despite being preventable, the influenza virus continues to cause significant illness and hospitalization in Canadian children. So our goal today is to review what is new for the 2025-2026 influenza season, highlight evidence-based approaches to improve vaccine uptake, and share practical strategies to address vaccine hesitancy in pediatric practice. So our objectives for this session are threefold. First, to review the 2025-2026 influenza vaccine recommendations, identify evidence-based strategies that promote vaccine uptake, and to discuss common concerns and factors that contribute to vaccine hesitancy. I'll begin with the first section, the flu, which focuses on current guidance, product updates, and administration practices for the upcoming influenza season. These recommendations are based on guidance from Public Health Agency of Canada, the National Advisory Committee on Immunizations, and the Canadian Pediatric Society. Even with long-standing vaccination programs, influenza continues to place a heavy burden on children, families, and the healthcare system each year. Next slide. Influenza is a respiratory viral illness caused by influenza A and B viruses. Seasonal outbreaks occur each year in Canada during the fall and winter months. Globally, influenza causes 3 to 5 million severe cases and between 290,000 and 650,000 deaths each year. In Canada, there's an estimated 12,000 hospitalizations and 3,500 deaths annually related to influenza and its complications. The impact is intensified when influenza coincides with other circulating respiratory viruses, such as COVID-19 and RSV. Next slide. Next slide. Vaccine protection decreases over time, and the virus strains in circulation change yearly, which is why annual vaccination is essential. Complications from influenza can include pneumonia, myocarditis, and encephalitis, and infection is also linked to increased cardiovascular events among high-risk adults. Children under the age of 5 are particularly important to vaccinate because they are both efficient transmitters and more vulnerable to severe disease. The Canadian Pediatric Society and NACI recommend universal influenza vaccines for everyone aged 6 months and older who do not have a contraindication. However, certain groups are prioritized, and these include children between 6 months and 5 years, children and youth with chronic medical conditions such as asthma, diabetes, or an immunodeficiency, pregnant individuals at any trimester, Indigenous communities, residents of long-term or chronic care facilities, and adults aged 65 years and older. We also emphasize vaccination for those who work closely with these groups, including healthcare workers, childcare providers, and household contacts. Next slide. So this slide we have a question. So which of these patients should be prioritized for influenza vaccination? You can write your answer in the chat or unmute. So the options are a 7-month-old with cystic fibrosis, a healthy 4-year-old, a 15-year-old with type 1 diabetes, or a 12-year-old with nephrotic syndrome. It's a bit of a trick question. So it's actually all of the above. Yes, exactly. So every child benefits from vaccination, but those with chronic illnesses face a higher risk of severe disease and hospitalization. But because the option B was a healthy 4-year-old, she's still in the age range that's prioritized as well. Next slide. So a frequent question in practice is whether immunocompromised children can safely receive the flu vaccine. And the answer is yes. The inactivated influenza vaccine is safe to give, although their immune response may be reduced. For these children, vaccinating household members and caregivers remains a key protective measure to reduce exposure and transmission risk. Next slide. So what's changed for the 2025-2026 season? This influenza season introduces several updates. The H3N2 strain has been revised, while H1N1 and B Victoria remain unchanged. The B Yamagata lineage has been removed worldwide, allowing both trivalent and quadrivalent vaccines to be used, with no preference for the quadrivalent vaccine in children. A new addition to the priority list of people to be vaccinated includes workers exposed to the avian influenza, such as poultry, swine, and dairy workers. These changes align vaccine production with the current viral landscape while improving protection for these high-risk occupational groups as well. Next slide. In Canada, there are 3 main types of influenza vaccines. The first is the inactivated influenza vaccine, which contains killed virus particles that cannot cause infection. It is given as an injection and is safe for almost everyone, including children, pregnant individuals, and those who are immunocompromised. The second is the live attenuated influenza vaccine, or a nasal spray vaccine. It contains a weakened form of the virus that can still stimulate an immune response, but should not cause serious illness. It is designed for healthy individuals aged 2 to 59 years. And the third is the recombinant influenza vaccine made using laboratory technology that produces only specific viral proteins instead of the whole virus. This avoids the need for eggs in manufacturing and is currently approved for adults only. Next slide. In Ottawa, influenza vaccines are widely available through pharmacies, primary care offices, public health clinics, and hospital vaccination programs. Most children will receive an inactivated vaccine, which protects against 2 type A strains and 1 type B strain. Multiple access points help reduce logistical barriers, but uptake ultimately depends on timing, accessibility, and the strength of our vaccine discussions with families as well. Next slide. So now we can talk about dosing and administration. For children under the age of 9, receiving the influenza vaccine for the first time, 2 doses are recommended, spaced at least 4 weeks apart. If a child has been vaccinated in a previous season, 1 annual dose is sufficient. For those aged 9 and older, 1 dose per year is recommended. and dosages vary slightly by product. So 0.25 mils intramuscularly for the pediatric adjuvanted formulation and 0.5 mils for the standard inactivated vaccine. For the live attenuated vaccines, 0.2 mils are given intranasally, 0.1 mil per nostril. Next slide. And finally, a few practical points about the live attenuated vaccine at CHEO. The LAIV can be ordered through KidCare and costs about $44 per dose. It's not covered by public health programs or most insurance plans, though some families may qualify for coverage through social work. A dedicated LAIV clinic run by our immunology nurse practitioner, Gabrielle White, will be held on November 14th for patients with confirmed large local reactions to previous influenza vaccine from the injection. This intranasal option can be especially valuable for children with a significant fear of needles, provided they meet the eligibility criteria that we discussed earlier. Next slide.
Okay, so now for timing, and when a parent asks you when they should give their child the flu vaccine, it's recommended to vaccinate as soon as the flu vaccine becomes available and continue offering it to parents until the end of the season. And the earlier you get the flu vaccine, the better your chances of preventing the flu. And the flu vaccine takes about 2 weeks to take full effect. In terms of effectiveness, the effectiveness of the flu vaccine does vary from season to season, and that depends on how well the vaccine strains match with the circulating influenza viruses and the type and subtype of circulating virus. And then it'll also depend on the health and age of the individual receiving the vaccine. But nevertheless, the key message is that even when there is a less than ideal match or lower effectiveness against the strain, patients that receive the vaccine, especially patients that are in the priority groups and high risk, will still be more likely to be protected compared to those who are unvaccinated. And while you're encouraging the flu vaccine, you can also encourage the COVID vaccine and the RSV monoclonal antibody vaccine if they qualify, because they can all be given at the same time safely. And the only caution with co-administration is with the live attenuated influenza vaccine. And that's where they say you should avoid giving the influenza antiviral within 48 hours before or after, which makes sense because you're giving the inactivated virus and then you're giving the antiviral against the virus. So it would not allow you to produce a complete immune response. But giving any other antiviral is actually safe to give at the same time as the live attenuated vaccine. And there are very few contraindications and precautions for the flu vaccine, but the one contraindication is a history of anaphylaxis after previous administration of the flu vaccine, or in a patient with a proven immediate or anaphylactic hypersensitivity reaction to any component except egg of that specific vaccine. So for the flu vaccine offered in Ottawa, the additional components would be the adjuvant, which is aluminum salts, or the preservative, which is thimerosal. So I've never heard of a patient having an allergy, but they must probably exist. And if they do, that would be a contraindication. And if you're ever wondering about any of the specific components of a vaccine, the constants are all listed on the Canada Public Health website. And then as for a precaution, influenza vaccine should be avoided in people who have developed GBS within 6 weeks of a previous influenza vaccination. Now, for the live attenuated influenza vaccine, there's a few more precautions, and that includes immunocompromised patients because it's a live vaccine, pregnancy, severe asthma, that's because they're often on oral or high-dose inhaled glucocorticosteroids. And other precautions are if patient is less than 24 months old, if they're currently on a long-term aspirin therapy, just because of the theoretical risk of developing Reye syndrome, and then if they have significant nasal congestion because it's a medication that's given intranasally. And to reemphasize, egg allergy is not a contraindication, and the flu vaccine should not be delayed because of minor or moderate acute illness with or without fever. And now we can see the impact of influenza specifically at CHEO. So very cool, on our EPIC dashboard, you can find the peak season metric meter, and you can see the number of admissions related to a specific virus. So for this table, we're looking at the admissions at CHEO, and I've put RSV, COVID, and influenza, and that's from August 2023 until now. So we get to see the past 2 viral seasons. So if we start off with RSV, which is the dark blue, We can certainly see that there's a lot of admissions secondary to RSV, but it does appear like the admissions have decreased in last season compared to the one previously, which does coincide with the new RSV monoclonal antibody vaccine. And then COVID is in green, which of course also leads to admissions, but we can see that in pink, which is influenza, it leads to more admissions. So our goal is really to try to decrease those numbers in pink with encouraging families to get the flu vaccine to then prevent hospitalizations related to influenza. And here it's a figure from the Canadian Influenza Surveillance, which they actually update this website every week with updated numbers. So we're also comparing to the two previous viral seasons. The red line is the 2023-2024 season, and then the yellow is the 2024-2025. And then the blue is this year. So we can see that there's already starting to be an increase in detections of influenza across Canada. And it seems to be happening sooner than it did last year when you're comparing it with the yellow line. And here's a figure showing the proportion of influenza detections in Canada this season, divided by age group. So looking at this figure, we can see that there's a lot of cases that are in people above 65 years of age. However, when you look at which age groups are included in every column, the first one is from 0 to 4 years of life, and the numbers are still similar to the rest of the categories, which have bigger age ranges. We also show that there's definitely a higher proportion of influenza A compared to influenza B detections, which is the blue compared to the orange. And then when you're seeing a patient in clinic, where can you tell them to get the flu vaccine? So usually most people will know about pharmacies or if their primary care provider offers it. For pharmacies in Ontario, they can administer the flu shot to children that are 2 years and older, but some pharmacies will only administer the flu vaccine if the children are above 5 years old. So now if you're seeing a patient that's less than 2 years old, they don't have a primary care provider, or the primary care provider's clinic doesn't offer the flu vaccine, where do you send them? So on the Ottawa Public Health website, it shows two other options that are specifically for high-risk people. And a high-risk person is considered a young child less than 5 years of age, or immediate family or household members of a child less than 5 years of age, or a newcomer to Canada without OHIP. So with this, a lot of the patients that you're seeing, even though they're above 5 years of age, this might still be an option if they have a younger child in the house that's less than 5. And the first option that there is the Neighborhood Health and Wellness Hub, which is drop-in. And then the second one is the Ottawa Public Health Community Vaccination Clinics, which are organized by appointments. And this is just to show you if you're thinking like, where is this accessible to my patient? Do they live close by? There's actually a lot of locations scattered through Ottawa for the Neighborhood Health and Wellness Hubs. And most times are during the day, which can be difficult for some parents that can't leave work, but there's a few places that are open a little later until 7 p.m. And then this is the two spots for the Ottawa Public Health Community Vaccination Clinic, and these are booked by appointment. And now, how can healthcare professionals encourage the flu vaccine? We've thought of a few of how to incorporate it more in the workflow already that we're trying to do it, but please put in the chat if you have any other ideas or things you've done at your clinic or seen done at other hospitals so we can create more opportunities for us to have these conversations with parents and their families. So the first way we thought about it was kind of building it even more in the clinic visit or a triage, so when they even check in for their appointment, that could always be a question just to plant the seed of, oh yeah, we're talking about flu vaccine. And then if they have questions, they can bring that up with the nurse that they see and then the physician that they see. During the medical history, during medication review with the nurse, and then during their stay in hospital is obviously something we're doing. And it's easier because we're seeing them from a longer period of time. And then who should discuss vaccines with patients? So as the Backstreet Boys said, everybody. So vaccine are not specialty specific, and really it's something that we encourage all healthcare professionals to discuss with their patients. As you've seen in Kristine's slide, many of your patients will be in the priority group given their age or their chronic conditions.
All right, so now we'll get into some of the facts on our influenza vaccine coverage, as well as some of the barriers and misconceptions that exist in those who are not vaccinating their children. Next slide, please. So this is very excellent data from Canada Public Health's Childhood Seasonal Immunization Coverage Survey, which was measuring the 2023 to 24 season of influenza, as well as comparing it to prior seasons. And here we can see that overall, only about 31% of children from 6 months to 17 years ended up receiving the influenza vaccine during the 2023 to 2024 influenza season. This is actually a decrease from previous years, in which 34% were vaccinated last season. So this shows especially like a drop and even a decrease in the most vulnerable, which is the 6 month to 4 year age range. So only 38% of this group actually received their vaccine in 2023 to 2024, compared to 41% in the previous season. So we're seeing that influenza vaccine coverage is not nearly as high as it needs to be, especially in those who need it the most. Next slide, please. This is again from the same data. So this actually shows parent and guardians' intention to vaccinate their child from the age of 6 months to 17 years of age against the flu in the next flu season. So it overall remained largely the same from previous seasons. So about 49% of parents and guardians indicated they definitely will or probably will get their child the influenza vaccine during the 2024 to 2025 influenza season. Which is unchanged from the previous cycle. We see similar trends in terms of last cycle. The younger the child, the higher was parental intention to vaccinate their child. But overall data sort of remains the same. But this raises the question, what is preventing parents from vaccinating their child? Because we are actually seeing drops in rates of vaccination. Next slide, please. So what are some of the barriers that exist that are obstacles to influenza vaccination? In the same survey, we actually saw that the majority of parents and guardians identified that they did not face any obstacles. So this would suggest that there are less like environmental barriers, but nevertheless, they do still exist. Oftentimes, access is a difficulty because of clinic hours and availability of appointments. People just don't have a way to get the influenza vaccine. So that was actually 8% of parents found that booking time off work or school for an appointment was an obstacle. Other times forgetting, so often forgetting that it's available, not knowing where we could get it is one that exists as well. And often they forget that a vaccine is even due for our regularly scheduled vaccinations. And trust was also cited as a very, very big one. So trust in the healthcare workers, trust in the healthcare system in general, trust in vaccine safety, a lot of misinformation as well, and misconceptions. So a lot of myths, such as their child being too young, although there is a very real age range where we should start vaccinating against influenza. And also the belief that natural immunity is superior. So these are ones that we frequently hear cited in terms of misconceptions. Next slide, please. So now, what are some common strategies that we can use to improve vaccine uptake? So these are some strategies we've seen in our routine childhood immunizations. So the first being mandatory school entry requirements. So we don't have this currently for influenza vaccine, but we've seen in Ontario and New Brunswick that they've made the childhood regularly scheduled vaccines mandatory for school entry. But we've also seen perhaps a shift in the landscape in society from one of societal responsibility to perhaps human rights and autonomy, where we're seeing perhaps a bit more friction and potentially negative publicity with making these school entry requirements mandatory for vaccination. And this can almost have an opposite effect. And there's still always the potential to bypass these measures with with religious or other objections for vaccination. We've also seen, for example, in Australia, implement financial incentives, but these outcomes and programs have yet to be studied and would also be difficult to implement in Canada. Next slide, please. Ultimately, our overall goal is to immunize for positive reasons and not for fear of reprisal, and with the ultimate goal of protecting those who are the most vulnerable and minimizing risk. Next slide. So what can we do to help improve uptake in vaccines in general? Always establishing electronic immunization registries to make sure that our vaccine records are easily accessible. Automatic notifications when vaccines are overdue, promoting the Can Immunize app, which is a way for parents to take control over their child's vaccines records and have them easily available. Obviously, addressing barriers to equitable access and making sure that all children can get vaccinated regardless of their socioeconomic background, ethnicity, or other barriers. And then mandatory immunization records that are accurate for school entry are also helpful, as well as other school-based programs for immunization, and also incorporating education into the school curriculum about vaccine-preventable diseases and why vaccines are beneficial and all the evidence behind them. Next slide, please. So now let's get into some of the myths surrounding why parents are not vaccinating their child against influenza. One that we've heard probably very frequently is it's just not necessary. And this is actually 56% of parents and guardians who refuse to vaccinate their child against influenza. However, we know that many people die from influenza and its complications every year, and it can even lead to very serious illness in high-risk groups. So vaccination is not just important to minimize severity of illness in yourself, but also protect others from infection. Next slide, please. Next question that we even hear from parents is it even effective? So 40% of parents have this question in their minds, and that's preventing them from vaccinating. So we know that there are many different viruses that people might consider the flu that are not actually the flu, and they cause these flu-like symptoms, but they're not actually influenza. So the vaccine does protect against strains of influenza that are expected to cause influenza during the season, but not against other viruses with similar illnesses, such as RSV, which has its own vaccine. The strains in the vaccine change each year to try and protect against the new strains that we anticipate causing the most illness during that season. And in some people, vaccination may not prevent influenza infection completely, but it can certainly decrease symptoms, complications, and mortality. So I think that's the most important thing to emphasize for patients. Next slide, please. Then many parents are wondering, is it even safe? That's 20% of parents. So influenza vaccines are safe. We have much documentation of this over the years. And most people will only have a sort of localized reaction. So redness, soreness, swelling where the vaccine was given. You could get mild symptoms with the live attenuated virus because you are giving the live virus, though inactivated. And GBS is a very rare 1 in a million complication from the vaccine, but it is much higher risk to get GBS from the actual influenza infection than you are to get it from the vaccination. Next slide, please. And then 20% of parents actually said that they just don't trust the government or pharmaceutical companies or the healthcare system, whatever that might be. So a large sense of mistrust, and we'll get into a bit of the post-COVID landscape in the next section. But mistrust is a hard myth to debunk, and it really has to be overcome with relationship. It's hard to find literature to support mistrust or disprove mistrust, but we can build rapport with our patients. We can be a great source of vaccine information and the influenza vaccine and complications of influenza. And what I did find in my research was that healthcare providers are among the most trusted individuals when it comes to vaccine information. So we should really leverage that in order to help our patients build more trust and have more trust in the influenza vaccine. Next slide. And then another one that we hear is, I got the flu from the flu shot. So like we said before, there are many viruses that can cause flu-like symptoms. So it might not necessarily be the flu that you're getting from the flu shot, but also the inactivated influenza vaccine cannot give you the virus because it contains those killed influenza viruses or parts of the virus that cannot infect. If anything, the live attenuated influenza vaccine contains a weakened virus, so you might get mild symptoms from that, but it's going to be much less severe and shorter lasting than the real flu. Next slide.
Great. So this section of the presentation is exploring the friction or the resistance that some families experience toward vaccines, and then strategies we can use as healthcare professionals to build trust, address concerns, and support informed decision-making. Next slide, please. Yeah. So like Hannah mentioned, a big one is the post-COVID influenza vaccine hesitancy. So I'll go through a few studies. This one is a Canadian study from Alami et al. Published in Frontiers in Public Health. They were speaking about different predictors of non-vaccination against influenza. These are a lot of the common ones, like residing in rural settings, parental education, attainment that's less than high school, absence of chronic medical conditions in these children, lower household income. They did also report that families mentioned that adherence due to the COVID-19 pandemic. There was hesitancy regarding the vaccine safety, the influenza vaccine efficacy, and the belief that the child is not at risk of the severe consequences from getting an influenza infection. If we look at two US studies, one of them, all of the references are in the footnotes, one of them said that there was an increase in parental hesitancy towards influenza vaccine for children post-pandemic. So if we look at the 2022-2023 year, they reported that 30.9% of children had a parent who were hesitant about the influenza vaccines particularly. Another study showed that influenza vaccination rates in children have decreased since the onset of the pandemic. So they reported that there was a 13.9% decrease in influenza vaccine post-pandemic compared to the rates pre-COVID pandemic. So what do we do from here? So this is a five-step approach to vaccine hesitancy, and this comes directly from the CPS statement on vaccine hesitancy. So we thought we would summarize the statement and to help with tips and tricks of what we can do. So what is vaccine hesitancy? The definition is really just a delay in accepting or refusing a vaccine for a variety of different reasons. And the ways to help approach vaccine hesitancy are to understand the key role that sound advice from your healthcare professional can play in parental decision-making, to use presumptive and motivational interviewing, to use simple and clear language, to reduce barriers to vaccine administration, and to reinforce the message that community protection does not necessarily guarantee personal protection. So in the next few slides, we'll be going through these steps a little bit more closely. So the first one is the key role of the healthcare professional's advice. Families have reported that they feel more understood and more listened to when the healthcare professional is non-biased, knowledgeable, patient, caring, and compassionate. The CPS recommends to never dismiss a parent or child from practice, even if there are different views on healthcare and vaccine administration. And in these families, it's important, when possible, to set aside extra time to counsel, important to keep up to date in the literature, and to tell compelling stories, whether it's to be personal stories about the consequences from vaccine preventable diseases, or if there's none that that you're willing to share or that you've experienced. Immunize Canada is a really great resource. It has a lot of really compelling stories about devastation from vaccine preventable diseases. The second thing we can do is use presumptive and motivational interviewing. So a presumptive approach is one that is more directive. So for example, saying Johnny is due for his immunizations today, whereas a participatory approach would be, oh, what do you think about vaccinating Johnny today? So this is more setting the landscape and phrasing it in a presumptive approach. Another great way is to ask open-ended questions, listen to reflectively to parents' concerns, ask about these concerns, acknowledge them, correct misconceptions when you can. Important not to spiral and go down a rabbit hole and bring up new misconceptions the family hasn't even addressed. Just stick to the ones that they've brought up. And then also addressing parental vaccination. So a great strategy is also to say, let's give your child the same health benefits and protection you received as a child, as most parents have been vaccinated. Next slide. Great. And then using simple and clear language. So a lot of times when it comes to vaccines and talking about vaccine safety and efficacy, we use a lot of statistics. It's important to use the same denominator. That's why it's an easy way for parents and families to compare what we're saying versus many different denominators, which can be quite confusing. Also important to frame our message positively. So saying the vaccine is 99% safe and saying only 1% of patients get side effects is technically saying the same thing, but the way you deliver your message can have an impact on the family. So framing your message by focusing on the positives is much more effective. And explaining to families that the disease complications, they may be a lot more serious than they anticipate, and they're not always correctable, even with medical care. And then, like Hannah mentioned, it's important to reduce barriers to vaccine administration. So some of these barriers could be the fear that a child may have around pain, needles, and the whole medical experience. So it's important to explain to children what will happen in advance. We can try coaching children through the procedure with deep breathing techniques, distraction with toys, topical anesthetics like EMLA. Next slide. Other things we can do is if they are in hospital, there's a supportive child life, as well as needle phobia workshops at CHEO. Other ways are to address the pain strategies and fear of needles through the CARD system. It's a system that describes different techniques, including comfort, ask, relax, and distract of the children. And there's resources that can help guide through needle phobia and how to use the CARD system in your practice. And so we put those links up on the screen. And then another take-home point we want to share with families is that community protection or herd protection does not guarantee personal protection. So the current levels of vaccine uptake are not high enough for herd immunity to really be effective. Another approach some parents like to adopt is the wait-and-see approach. That means just holding off on giving any vaccines, and if their kid gets sick or if there's an outbreak, then trying to give the vaccine. This actually increases the risk of harm because we can't predict when an outbreak will occur. And some vaccines require many doses. Some of them, the timing of the effect onset is longer. And so waiting and seeing is not actually the most useful approach. Another important thing is to remind families of their responsibilities to others, to their family, to the public. So healthy, unvaccinated children, although they may do very well, they can actually spread a vaccine-preventable disease to vulnerable populations. This is reminding families of other immunocompromised children in their surroundings. If there's infant siblings that are too young to get vaccinated, pregnant friends who are at risk, or vulnerable grandparents. And this is a responsibility we have to protect those around us as well. The CPS statement about vaccine hesitancy actually added an addendum in October 2024 with 3 new recommendations that we wanted to highlight. So the first recommendation is to be sensitive to the lived realities or racialized and Indigenous parents and the resultant distrust in the healthcare system because of these lived realities. The second recommendation is to directly address issues of pain and anxiety when it's raised by parents and when it's raised by children. And talking through these fears can actually help with vaccine uptake. The third recommendation is to help facilitate or refer to specialized clinics. These are clinics with vaccine that address vaccine hesitancy, and so they have a little bit more time spent with patients. They have child life present. Like we mentioned a little bit earlier, there's after-hour clinics for parents who work shift work or work longer jobs. And then there are specialized clinics that are culturally sensitive for patients who have experienced lived realities of racialized or Indigenous experiences. And lastly, our last flu points, and that is, where can we get the vaccine? So for our staff here at CHEO, where can we get the vaccine? So there is a vaccination table set up near our Occupational Health and Wellness Center, and they are set up Tuesdays, Wednesdays, and Thursdays from 10 to 2. You don't need an appointment. You can just walk up and get it done. There also are flu champions on the inpatient units and in the different departments that are roving around and are able to administer the flu vaccine in the middle of your day, so you don't have to displace yourself from what you're doing. If you don't find a flu champion or you can't make it to the vaccination table, the Occupational Health and Wellness Clinic is available daily, Monday to Friday from 8 to 3. They can give you a vaccine during that window. You don't need an appointment. You can just drop on by. And then for our weekend workers, there will be a nurse who will be roving through the different inpatient units Saturday, November 8th, 15th, and 22nd, and can give you the flu vaccine on the shot. So that is great. The next slide here just speaks about the other places we can get vaccines. This would be for either our staff who can't make it to the availabilities on the previous slide, or to recommend to our family, friends, and patients. So like we mentioned, there's pharmacies, there's walk-in clinics, your family doctor's office, or the Ottawa Public Health clinics that we spoke about a little bit earlier. And these are running all the way through the end of the flu season. So take-home message, please get your flu shot today. Recommend to your family, friends, patients to get their flu shot today or as soon as they can. Thank you for tuning in to our Grand Rounds presentation. We'd love to hear your questions or your comments or experiences on discussing vaccine hesitancy and vaccine uptake with your patients.
Great job, guys. Sorry, I just realized I'm on the web version of Zoom, so it's just behaving a bit differently. Again, thanks. That was a great presentation. My daughter in grade 9 is here with me today for Bring Your Kid to Work Day. She also thought it was a great presentation, and I was happy I had her with me because she was able to identify that band for me for the Everybody song. I think I saw a question in the chat. I had one. Oh, okay. There are a couple of questions in the chat. I had one question just in terms of kind of the dynamics of immunity and what we usually see. So, you get the flu shot, maybe how long does the immunity usually last? If we have kind of a later flu season and we immunize too early, is that a phenomenon in terms of timing and when you usually see immunity kind of peak following vaccine. And I see we have Chuck and Ann in the audience as well, who may be better placed to answer that question. But if I was kind of curious, when you were talking about the wait and see, and yet we have all these resources like the Health Canada flu website, and you can sort of see when it's rising. And, in the past, I've tried to time my vaccine a bit. So just as it's rising, get the shot, and but I was curious about those kind of kinetics.
Maybe
if you don't know, I'm happy to get in. Oh, there she is.
maybe I can jump in quickly. So we know that the influenza vaccine obviously requires a yearly administration due to the changes of the strain, but also
yeah. Are you okay?
Hello. Also the
immunity. No, we're good.
Okay, can you hear me?
Yeah, we can hear you. It was just there was an unmute, accidental unmute.
But we do know that the immunity actually does wane. So actually on NACI, so the National Advisory Committee on Immunization, we're actually looking at this specifically.
You bounced up pretty fast.
Hello? The issue of intra-seasonal waning. We do know that in the elderly and in immunocompromised patients, the protection probably wanes faster, anywhere between 3 to 6 months. For healthy children and all that, probably it persists longer. So this is something to look at. We haven't, there's no, right now the recommendation is to get it as soon as you can, because we cannot necessarily predict. I mean, we have an idea of when influenza season peaks. After after a flu vaccine, your protection probably peaks within the first few weeks to the first, 1 to 3 months, and then it kind of starts to wane. But right now, I wouldn't say to wait it out and get your vaccine, because you don't know. And as you saw on the graph, we're starting to see a pickup, and so nobody has a crystal ball to know if you would be to encounter the virus. So, but that is something that we're looking into. So stay tuned for the 2026-2027 statement next year, because we'll probably have some more data on that.
Great. Thanks, Anne. And there's a series of 4 really good questions from Rob Czar in the chat. So if anyone can see the chat, you can see the questions there. The first one is, are the majority of anti-flu parents, flu vaccine parents, also anti-vax parents in general, or is it a separate, unique group?
I guess I can start with that. We, as part of this, we kind of did like talking with parents and asking them about the flu vaccines and other vaccines, just to see. We've already been doing this throughout residency, but to see what the reactions were. And in what I've seen, it's actually two separate groups. A lot of patients that I saw had their routine immunizations, but didn't get the flu vaccine. I'm sure in Dr. Famuyi's clinics, she probably maybe seems where the overlap, but that was most of the groups I saw in the clinics over last month.
Yeah, I agree. There's definitely some overlap where some groups are anti-vax against all types of vaccines, but then even in immunology clinic recently with Dr. Famuyi, we had one parent say like, I vaccinate for all childhood vaccines except influenza. That's the only thing I avoid, and COVID. And there's a couple different reasons that we touched on, but I think one is that the fact that they have to take it annually, and they consider influenza to be a more mild version compared to the diseases that you experience with the childhood vaccines. There's a lot of different reasons, but yeah, there definitely is a group that just avoids influenza vaccines but will still vaccinate for the childhood vaccine.
Yeah, one of the things I asked this group is like, as you're presenting, do it in real life, like just talk to, offer the influenza vaccine and see how families react. And I agree with what they say. I think one of the messages is never assume that, everybody has the same vaccine hesitancy or the same concern. Everyone is different. So the first thing is, as they presented, is really to listen and build that trust. But sometimes the reasons are, not what you expect. So, but yeah, it's not a homogeneous group.
Yeah, thanks. I'll jump to Tom's question in the chat because it again is around hesitancy. Is there data whether vaccine hesitancy rates differ between dads and moms? So is there any sort of parental or guardian kind of stratification in terms of where hesitancy is more often seen?
Interesting.
If we don't know that.
Yeah, it's an interesting question, and I've seen it like brought up in another forum, but when we looked at it or discussed, it was not a clear, because there was I think there's been a shift and a change as well. So I don't know actually the numbers, but it's an interesting question.
Yeah, and I think it's an interesting one. If I go back to my newborn screening background in terms of public health type population interventions, often you do see parental differences, but often non-maternal opinions and thoughts are not studied. So it's often actually hard to know if there are differences. Rob's second question was, what factors determine when flu vaccination is available in Canada, and how does that compare to other parts of North America? And I'd be curious globally as well.
So it's a bunch of factors with availability, authorization, and all that. Obviously it's in the fall, but the exact date of when the program is launched is from a programmatic provincial territorial aspect, because the strains are selected obviously by the WHO, incorporated, manufactured, and so the release date of when the official launch is under the provincial and territorial programs. I don't know if that
And does the timing tend to be similar in in different jurisdictions?
Yeah, it's similar in North America. There is generally some prioritization for the high-risk groups. So sometimes the vaccines are available in like long-term care facilities before they're for the public. This year at CHEO, as we saw, it was available in the community before the hospital, before high-risk patients. So anyways, a few little glitches, logistical glitches, but in general, it's in the fall, kind of at the similar timing in North America.
Right. Third question was, are there plans to combine COVID and flu into one vaccination? So kind of polyvalent vaccines around the seasonal infections.
Yes, there's an mRNA combined COVID and COVID-19 and influenza vaccine being studied, and And it, I guess in a nutshell, it's still going through submission and approval process. So maybe in the future. So it's in the works. Not yet ready for prime time.
Great. Last of Rob's questions. Does CHEO require all staff to be flu, RSV, I'll say, and or COVID vaccinated?
No, but strongly recommend.
Yeah. Okay. I'm just going to go to, we have a lot of questions in the chat. Jeff Gilchrist noted that there's a great Kurzgesagt video, which I've watched. It is really good. That's a good recommendation. And then Erica had a question about nasal live attenuated vaccine. Is it still considered to be more effective in children than the intramuscular vaccine? Does the nasal LAV result in any viral shedding? And can this pose any risk to immunocompromised household contacts or even patients if this vaccine was administered to a healthcare provider? Any of the residents want to tackle that one? That's a pretty complicated one. That was a great question.
I think in the past, earlier studies, like I think pre-2015, it was found to be more effective than the inactivated influenza vaccine. But I think more recently, there's been more evidence to say that it's not, and they have the same effectiveness. But Dr. Cummings obviously knows more about that.
No, it's correct. So like back in the early 2000s when it was first authorized, the first few seasons we saw like really amazing vaccine effectiveness, especially in the young children. And so actually both the American ACIP and Canada's NACI, we made a preferential recommendation to give the live attenuated influenza vaccine to young children. But over the years, there was some seasons that were very problematic. There was an issue, I mean, it's a bit complicated. There was an issue when the influenza A, like pandemic strain, the 2009 strain was incorporated. It wasn't as fit to replicate. And so we saw a decrease. There was some issue with the cold adapted. And so there are a few issues with the vaccine. And then we saw actually a decline in the vaccine effectiveness compared to the really robust that we saw in the early years used. And so what happened is that the preferential recommendation was removed. And so the current guidance is any influenza vaccine may be used. And then some season it changes. Some seasons it had really poor vaccine effectiveness. Some were comparable to the other inactivated as well. So right now, as you saw, it's not publicly funded. There were a few years where it was one of the options that was publicly funded. You can get it, and there are some select patients that needle phobic, especially like what was mentioned in the talk, or if they've had large local reactions, that it might be preferred, I guess, or to use that. But in general, we moved to the inactivated for most children, and that's what the programs have done as they publicly funded. And in terms of the shedding, it's not we don't give it to immunocompromised specifically, but the shedding, it's not a huge concern. So if you had to, you could.
Yeah, I was curious about, if a healthcare provider were to have the live attenuated and then sheds, could that, like, for example, if you had the live attenuated and you're going to your, primary immune deficiency clinic, is that a problem in terms of potential shedding?
I mean, I wear a mask, but if in general, it's like very low. So it's really for the individual that's immunocompromised that's most concerned. But to be honest, we have the way it's worded is a bit like implicit, like implied that unless you had a reason not to take the inactivated, if there's any kind of, there's a theoretical of anything, but in general, like you could still, if you had to, let's say the seasonal was, the inactivated was a contraindication, you could still use the live attenuated.
Great. We'll go to Dr. Batra's question, and then we have a couple more in the chat, and I think then we'll call it the day. So, Dr. Batra. Okay, maybe
Hello?
we'll go to the, there we go. Yeah.
Yeah. Okay. Yeah. I was wondering if there's any benefit of giving 2 injections, say one in the beginning of fall and beginning of winter, say November and January or February months.
Yeah, so a bit like this is the issue that we're looking in because at NACI, so there's no official guidance. We just know that some individuals wane faster. And so, for example, I said that we prioritize the elderly in the long-term care facility. So some of these individuals receive their vaccine like in September. And so you would guess that by March, maybe their immunity is low. So we're reviewing to see if there would be benefit to add another dose, but currently the recommendation is just a single dose per season, but being looked at.
And kind of a follow-up on that, is anyone looking at the cost effectiveness of this, like the, kind of balancing, the health benefits and the system costs? Because, I could see it going either way, on a 2-shot system.
No, for sure. And again, with NACI, it has a whole EFA framework. So like in terms of ethics, economic feasibility and acceptance. And so we are reviewing what is the economic acceptance, et cetera, of providing any recommendation that is provided or so like what's the impact of a 2-dose recommendation for select population, for example. So yeah, it would be to balance that.
Yeah. So we'll just go to Nia's question and end off with Katie. So Nia's question is the COVID vaccine equally as strongly recommended for less than 5-year-olds? I've had many parents trying to reduce needles and asking if they should prioritize flu or COVID.
I'll let the residents respond first, and then I could talk for hours about vaccines. So again, even after these rounds, if you have questions, you can email me, message me, call me up. Anyways, what do you think?
Sorry, Kristine, you can hop in because you're more of the immunology expert, but I would imagine it would be equally as strongly recommended, especially in younger children. But Kristine, if you have more insight into which would be a priority if people were refusing to do both.
I was going to say the same thing.
So there is a little bit of nuance because we've seen, the COVID-19 infections in children have changed a little bit from the start of the pandemic to now. So the current recommendation, on NACI is become like, so for COVID-19 vaccination, it's become more of a targeted program targeting the high risk individuals that are predicted to have severe COVID-19 disease. And so most of us working in pediatrics have seen a significant decrease in severe disease caused by COVID-19 in our patients. The highest are the elderly. So it's really the age. The older you are, the highest chance you'll have a severe disease, and then a lot of different chronic medical conditions, immunocompromised patients, et cetera. So for the healthy children, actually, it is on NACI, we have this language of you should get it or you may get it. So it is a may recommendation. So you may get it. It is authorized for children 6 months and above. But if your child is not in the risk group of predicted to have severe disease, then it's not as strong, the recommendation. And that's kind of how I frame it for my patients when I counsel about the flu vaccine and the COVID-19. I said, depending on the age and all that, I said you should get the seasonal influenza. You may consider as well. And I think in many situations, we know that the immunity from SARS-CoV-2 in children is not lifelong. It's not one and done. And so kids will get again and again. It acts a little bit like a seasonal coronavirus. And if you want to boost that response, we know the vaccine works very well. So if you're traveling, if you have, I don't know, you're about to go to surgery, you just don't want to get another illness. And I think it's very good in that case. And then we have good safety data. It's the most studied vaccine in our contemporary times. So when families say, oh, it's not been studied, like I roll my eyes and then I go, no, I don't roll my eyes. I listen.
Yeah. So
Yeah.
as Anne mentioned, she could talk about this for hours. It's a passion, for Anne, and she's very knowledgeable. So I do call her around vaccines. One last question though that I wanted to get to from Katie. Can you comment on the updated indications for Tamiflu this season, and especially for young kids, lesson 2, lesson 1?
Give it.
Well, I haven't looked at the guidance from the AP and the CPS, but she knows that they differ. And so I think that's maybe where the questions especially
I
come
would
from.
say, because I think Nicole just reviewed that to put it in the app, or I'm gonna put Nicole. I don't have the comparison of the two. I'm not aware of the.
Okay.
Or we can. I know it's overtime, but.
So maybe reach out after and check the app. And but great question. And one sure that's going to be coming up more and more in the next couple of months, and hopefully fading away. So thank you again. We're just over time. We peaked at 112 participants, so I think you had a broad reach, and great presentation. Thank you again, and we'll sign off.